Today's topic is cultural aspects of care. One of my disclaimers is that I am not an expert at all, other than what we learn in geriatric training and our general readings. I'm not particularly a content expert in this topic, but I will share with you some of the information that we've gathered through our healthcare and educational partners, as well as some of the information that we get from the American Geriatric Society. So a lot of these slides are actually a modification of curriculum that we've create through basic slides that come from the American Geriatric Society. And with that said, I just want to remind everybody that these presentations are supported by HRSA as part of the Geriatric Workforce Enhancement Program. I keep forgetting to put our logo up, for the Geriatric Workforce Enhancement Program. And for those that are tracking our progress on that, it's a 5-year grant that started in 2019, and we're looking to hopefully renew it, and hopefully we'll hear shortly for another 5 years. So lucky you guys get to hear me for another 5 years if we get the grant. Well, you get to hear me anyways, but however that goes. And we invite others, who are interested in helping us with these presentations, as all of you are becoming geriatric content experts, because I can see a lot of folks here who have been following the series for quite a while. We certainly would like to invite you to do some presentations likewise. Okay, so the goals today are to recognize the impact that cultural and also spiritual beliefs might have on health-related behaviors and also preferences. And then the important admonishment is to try to guard against stereotyping, which sometimes is just difficult to do because of a variety of reasons that we'll talk about. We also want to generally work to simplify healthcare messages. I mean, this is a huge question that I always present with our doctors in training, because they'll have a very technical explanation of something. I'm going like, he says, do you think the patient understood anything that you just said? It's like, and then they reflect that and go like, well, maybe I could have done a little better job. And then we're going to focus on Native American elders or older adults. And so this particular presentation has a little bit of connotations for long-term care that you'll see. It's part of our national curriculum that we created for HRSA. So it does have a little bit of a lean, if you will, or a nudge towards long-term care. You'll notice that I'll have with each of these slides a visual, some imagery that here we have the Claude Monet painting of the early sunrise, and you can see there's a lot of fuzziness in the foreground with what appears to be a sailboat next to the lighted waves. And I think this part is appropriate type of painting for us to consider cultural aspects of care, because there is a lot of fuzziness in terms of both our knowledge and our day-to-day application of that. So that's why I chose this painting. So the big conundrum is, where do we go as a society? On one side, and I grew up with this. My grandparents were immigrants from Eastern Europe, and there's this whole thing of like, I didn't get to learn my Lithuanian heritage language because they said, well, you're an American now and you should learn English, and we don't speak the old language. So there's this whole concept that cultures should transcend differences, and that we should all be one. And then that contrasts with celebrating multiculturalism. One of the things that I so enjoyed in Chicago in particular, when many of my career years were spent in Chicago, or was going to all the neighborhoods. You had Little Italy, you had Little Poland, and so forth. Those all were, great for little restaurants and so forth. And so that's multiculturalism, and it's to celebrate the different cultural traditions and recognizing contributions of all groups to American society. So another interesting artist here, Georgia O'Keeffe, looking at this whole question of, environmental changes. She always focused on the desert and always had flowers next to, as you can see here, I think this is a steer. I don't know, maybe, yeah. That's, a skull, what am I looking for? A skull of a steer. So she always contrasted living things with, it's part of the cycle of life, I guess, is what we're trying to represent here, death and flowering and life. But anyways, there is an important point is that cultural and religious diversity is on the rise. So within the next 10 years, basically, we're going to have at least 33% of Americans are going to be from traditionally what we consider underrepresented backgrounds. And I remember back with former Senator Heidkamp, she gave a talk one time in Fargo, and she says, this is not your North Dakota that your grandparents knew about. And I think this is true for most areas in the country now that we're seeing a huge diversification of population. So the important thing for healthcare workers is that the therapeutic relationship may be influenced by the healthcare worker and the residents' cultural and spiritual beliefs and practices. And so there's always this potential tension, between the provider and the patient. And as we look at the so-called dyad relationship, we always have to ask ourselves how that might be influenced. So here's a Van Gogh painting that we can see with blackbirds flying into the sky. And there's this pathway down the middle. And so, but it ends. And so the pathway ends abruptly. And why is that? So hey, these are not artistic interpretations. These are my own, self-made or whatever. Interpretations of paintings, and I'm sure that our UND art faculty could do a heck of a lot better job than me. But so I picked these paintings out for particular representation, and one of them just that struck me was this, the flight of the birds, who seem to have an endless pathway versus people on the ground that sometimes come to a dead end. So in order to develop cultural competencies, we need to have some knowledge and we need to have some skills. So one of those things that are represented is the preferred greeting gestures. Should it be a handshake? And of course, COVID did like no handshakes. It was like maybe a fist bump. But perhaps for somebody else with Eastern Asian culture, it may be a hand clasp and a bow. Maybe the handshake is not so aggressive. A lot of times, growing up as a young man, I was always told that your strength was, identified by by your grip strength. And in some cultures, that's not too impressive. That actually demonstrates that you're trying to dominate somebody. By the same token, if you ever seen some politicians, when they go and take a handshake, they grab the other person's hand and then pull the person right into them. I mean, that could really be culturally insensitive. So things like that we need to consider. We also need to consider the beliefs and behaviors. So there might be dietary restrictions, as we talk about, for example, nutrition in older adults and how do they get, increased protein in their diet. They're supposed to get 1.5 grams per kilogram. It's a lot of protein. It's about 70 to 80 grams of protein. And, if you're a vegetarian, how do you get that, right? And usually when I bring this up, people's first response to me is like, well, I eat a lot of meat, so that's good. And I think to myself, well, maybe you shouldn't be eating so much meat because you got high cholesterol and you had a stroke, a couple of years ago, and let's talk about that. The other part of the competencies is ultimately to demonstrate respect, and I sometimes that gets lost on folks. We're so driven by our clinical encounters is that we just don't really back up and reflect on, how we interact and whether we demonstrated respect. So one of those might be, for example, I had a conversation with a Native American leader, and he says, you doctors are all the same. I said, yeah, what's that? He says, well, you keep asking questions one after another, and you don't really wait for an answer. If you don't get an answer in 2 seconds, then you move on to the next question. So I thought that was, very, very revealing. Oh, here's a picture of self-portrait by Max Beckman. So this actually painting or portrait was located at my college. There was an art museum on the college campus, and I just like the sort of colors, very basic colors of this particular painting. But it also kind of represents this question of formality, right? This guy's in a tuxedo, and he's kind of, I don't know, hands on hips, but he's still kind of stiff looking, right? So sometimes you need to be mindful of somebody's either fear of coming into the clinic, right? If they're hesitant or have fear of the provider, they may not be as responsive to some of the questions. So it's always important to use somewhat of a formal communication, certainly asking the older adult how they like to be called. Is it, by your family name? Is it Mr. by your first name? And so generally, I when I go into a clinic, I'll just, state the name on the we get a little piece of paper or sticky paper that identifies the patient's first and last name. So I start off and say, so-and-so. And then if they're new to me, I said, how do you like to be addressed? So here we have a painting by Brunnan, who's basically somebody from, looking with his bifocals there, looking at the list of things. And, so there's always a checklist and language, right? So this sort of represents the whole question of literacy and language. And it's tough. Most people just don't speak in healthcare terms, right? And they're not what we would call proficient. And we also need to establish whether English is really their preferred language. It's interesting because a lot of older adults who English is not their first tongue or their language still want to speak English or prefer to do so because they think that it's a mark against them if they have to use an interpreter. Right, so they don't want to disappoint, the provider. So sometimes, we really have to ask and probe a little deeper into whether they fully understand, and then also the whole issue of having a family member. And again, the axiom is to have an interpreter, regardless of what the family says. But a lot of times, patients just really insist on having a friend or a family member be their interpreter. But as you can imagine, that sometimes gets a little tricky because if you're concerned about things like elder abuse or neglect, you can't exactly, and if the family member is part of that process, it's not like a good situation to be able to ask them to interpret while you're asking the older adult, is this person who's interpreting for you make you feel safe or not? A little bit of a line drawing here. I don't know who this was attributed to, but there's this whole thing in art where you put the pencil or pen on the paper and you just keep drawing the figure without ever lifting the pen off. And so that's what this is all about. This is actually something that we're going to try, by the way, with our health promotion program at Spirit Lake. We go there monthly to meet with the older adults at their Elders Day Out. And this is one of the, so we do art with them and in group, and this is going to be one of their projects coming down the line here. So communication strategies, it's really important to realize that, my waving my hand or, my furrowing my eyebrows, 2/3 of our communication comes through non-verbal cues. And so your body posture, whether you're standing upright or slouched over, whether you're looking away, those are all verbal cues that can really either enhance or detract, from the conversation with older adults. It's important that you really assess the visual and hearing issues. Older adults like to be spoken at directly. Sometimes they lip read, and so you can imagine if you're in front of a computer and you're talking to them and spurting out all these questions, if they can't lip read, that's going to be tough. And so that's why it's always important to turn towards the older adult patient and make sure you speak in a low and somewhat slow tone. You don't necessarily have to speak more loudly. It's just the lower tone is really important. It's also important to really keep just a few points. A lot of times people will go through this barrage of questions, and yeah, you're trying to be comprehensive, but really, 3 points is about the max that you're going to resolve. And then a lot of use of repetition is important. Although one time I did get reprimanded when the older patient said, "I heard you the first time." And I said, "Oh dear." And then also with communications, open-ended questions. One of the questions I like to ask, if somebody comes in with a complaint with knee pain, for example, I says, "Well, what do you think is going on?" Right? And so then they sometimes they'll give you the diagnosis. And then finally, this is very common in the nursing education literature, is that you try to verify the understanding that the older person has by a teach-back methodology. Ask them to tell me, okay, what did we just talk about? And I'll say, this is great. I'll hand them their after-visit summary, and I say, now tell me, and I just ask them 3 things. I said, when you go home, what are the 3 things you're going to do? And then if I get this blank stare, I know nothing got absorbed. So then we start all over again. Again, just emphasizing the nonverbal communication, whether it be hand gestures. You can see the different facial expressions here. Sometimes physical touch can help reinforce, and on the other hand, sometimes people don't like the physical touch, and it really depends on particularly if somebody's agitated. You don't want to be touching people if they're in an agitated or angered state. Eye contact generally could be good, but sometimes people will look away from you. And again, body positioning is important. Not too close, not too far, right? So those are important things. Also, in terms of just announcing what you're doing on your physical exam, because some people are visually impaired or hearing impaired, and I'll just state, well, I'm going to take a look in your ears now, and then approach the patient in that manner. You always want to look for, I say resident, but it's the same, patient responses. If you see grimacing or eye squinting, or if they turn away from you, those could be sensitive areas or responses to touch. And you can also ask patients' preferences, in terms of whether they feel comfortable sitting down, lying down, even before you ask them to get into a particular position. So, for example, we'll do Dix-Hall-Pike maneuvers, for dizziness. So that requires the patient turning their head to one side, and then we lie them back with their head dangling over the edge of the exam table. And some people say, "Oh God, my back is so bad, I don't think I can do that." So that may be an instance where we can't really perform the test. One of our local artists here, Hillary Kempenich. This is one of my favorite paintings of hers. Sort of this older Native American woman raising her arrow in defiance, which and I don't know the history of all the flags behind her, but you can also see there's multiple stars in the sky. So this kind of relates to me to the whole history of trauma. And this involves refugees. So like in Grand Forks here, we're getting about 100 refugees per year, which I don't know, that's not such a big number compared to some of the other metropolitan areas. But however that is, one can be assured that the vast majority of those individuals have had some form of post-traumatic stress syndrome through whether it be through physical altercations or mental abuse. there's a lot of issues that are really hard to dissect, right? Because a lot of times these folks just don't want to convey, what their problems are. So you have to be mindful of that. Just to build on this whole question of historical trauma, and again, I'm not an expert. I'm just relating to you some information that is considered important in cultural competencies. I look at this Frederick Remington, I think it's a drawing, and it's interesting because he labeled this drawing between a cowboy and a Native American riding together, questionable companionship, and you have these two horses looking at each other like with big wide eyes, like not quite being sure of what's going on. And so I think this is the whole issue of how do people interpret historical trauma, and certainly understanding the psychological wounds that have been passed down through generations. When people talk about the legacy of boarding schools, grandparents. I mean, we just had another conversation about hair locks of a grandparent being archived at University of Pennsylvania for future genetic studies. And grandma was 13 years old at the time, and not that may necessarily have been, a trauma, but it's still sort of like, the whole question, who asked for permission, and what's the legacy of that? Certainly the whole issue of forced removal and relocation to lands that were disrupted, firstly, and denied. Lands that were, I was astonished that they're in western North Dakota. There's a huge, the whole western part of the state basically is still under, or should be still under tribal oversight. But that treaty was just totally ignored, and now we are here, how many years, later. And then also just the whole issue of the just unmitigated violence that these populations endured, and more recently the environmental interventions, that we all are familiar about, particularly recently with the oil pipelines tracking through and going through waterways that tribal organizations require. So those are some of the issues that we need to concern ourselves with. The other thing and this one, I honestly to gosh, I really struggle with this whole issue of microaggressions and subconscious bias. I mean, one part of me tells me, yeah, right, this is a term that, is being thrown around there. And, we've all got things that are just, that it's very Freudian, right? It's like, id, ego, superego. And I don't know. But again, the interpretation is that this is a subtle and commonly unintentional behaviors or remarks. And I'll give you some examples here of how that's represented. But basically, it conveys, these negative attitudes towards members of groups that are not part of, white Caucasian prominent groups. So here, this Picasso painting, I'm sure you're all familiar with this, the Spanish Civil War and the horses and the animals all, being in anguish, and there's a lot of hostility in this mural, and so it relates to this concept in my thinking about microaggression, that these are behaviors that can be expressed in various ways, whether it be in language, tone, or gestures, I think we can reflect on a variety of ways, particularly with gestures and just how we might express ourselves or mimic or imitate or mock, I think is the right word I'm looking for, certain groups because of certain ways that they maybe walk, dance, and so forth. So here's some examples. So making assumptions about somebody's ability based on their identity or appearance or background. So if you think that a certain group is, has such and such qualities, and you just make that assumption that, well, here we go again, probably not such a good thing, eh? And then also just using language that that implies inferiority. So we always have to be careful that how we express ourselves. And I mean, even saying something like, well, I mean, particularly with the wealthy, versus not so wealthy people, you might assume that somebody comes from a background, a particular racial background, and that they actually may be from wealth, right? And you're making an assumption that they had an impoverished background when in fact they did not. So I was just reflecting on there was a congressional hearing on the safety in the airline industry, and there was a gender bias that was expressed by one of the senators who asked the one of the women who was being interviewed what it was like to be a stewardess, and she says, "Well, Senator, I'm a pilot. I'm not a stewardess." So there you go. Implicit bias, right? And then also finally, just microaggressions could be dismissing somebody's experience or feelings. If they say, "I feel threatened" or "I feel unsafe," exactly what does that mean? So to really appreciate that and do a little deeper dive into understanding that. Some additional, specific examples of microaggressions: somebody saying, "Oh, you're so articulate," for somebody from your background. They're not specifically saying who that background is, but it's obviously inferred. I love this one: "Pretty woman," right? You're pretty smart for a woman / pretty woman. So again, additional biases. And then really a positive statement, right? I'm not biased. I don't see color. I treat everyone equally. Okay, well, that's your word versus your actions, and so who knows? Or what about the disabled? You don't look disabled. Do you really need accommodations? And that could be anywhere from dyslexia to aphasia. I have a family member who maybe a little hearing impaired, but you would not know that there was a aphasia, right? That this person seems to be nodding their head, but is not understanding anything that's being said. So these are things that we may not fully appreciate. And then this final comment: I don't see why we need a whole month dedicated to Native American history or Black Americans or whatever. So it's always that concern about well, that's just viewed as a microaggression when you diss somebody's celebratory. Remember that whole comparison: are we a homogeneous society, or are we celebrating multiculturalism? Getting back to trauma-informed care, and then this is just the emphasis on long-term care. We have a kind of a curious painting by June Leaf, where there's this battle between two conquistadors on these very long-legged horses, I guess, and they're forming an arch and a gateway into someplace that we don't know. What's going on there. So it's a very intriguing painting here. And we know that American Indians experience trauma more often than the general U.S. population. That's just a general statement. Their life experiences may be combined with the historical trauma to create complex psychosocial issues that, when under stress, may become manifest. So a lot of people have been focusing on trauma-informed healthcare. It's kind of brief there for TIC, that can promote healing among Native American elders who experience trauma. So I guess the important part of that message is that, firstly, identify if and how somebody has experienced trauma somewhere in their either directly themselves or indirectly through a family member. and then to further understand that and to understand how that's impacted their lives. So there are programs that have been developed for trauma-informed care. And firstly is always, and I think generally, creating a safe environment, trying to develop support through peers, which is important, and involving family as best possible, where family members are of interest. Sometimes a lot, in terms of caregiving, we have to develop the caregiver training to help people understand, particularly with memory loss, because a lot of family members get real frustrated when, let's say somebody like a doctor asks the patient a question and they say, come on, mom, you understand that, you know the answer, and it just ends up putting more stress on the individual. And so sometimes you have to turn to the family member and say, we don't need to push the issue, right? If they get it, they get it. If they don't, we let it go. Kind of go with the flow concept, right? The other part of trauma-informed care is to empower folks so that they can do things that are important to them, whether it be, through nonverbal expression, either through art, music, dance. These are all, kinds of examples that you want to try to tap into. A big one is trust and open communication. Certainly it takes time to build trust. And that's just true in medical practices, right? I mean, somebody sees me for the first time, I was like, no way they're going to trust me with, that's doctor's advice. Like, really? It's like, it may take a few encounters before we get to some level of trust and understanding. And also the other point is it's a team, it's a team approach. And so in dealing with patient care, it's always helpful to have these collaborations. And in these collaborations can range from working with a pharmacist to a nurse physician, relationship for, working with a particular patient, or psychology, or what we call integrated health, which is focused on mental health issues. And again, a lot of it depends upon assessments, right? If you don't know the person's anxious, or if you don't know the person's depressed because you didn't screen for it, I mean, that's just going to go right over, right? So there's no way that the team can address these responses, and that's why we've always had this theme of promoting the geriatric 4Ms, and one of them is the mind, right? We need to screen for memory loss. We need to screen for depression and for anxiety, and we need to screen for social isolation and loneliness, right? And how many times does that happen in the clinic or other settings? So in terms of considering safety, certainly adaptive equipment to help avoid falling, and emphasizing the fact that maybe, you really should use your walker, because a lot of times older adults feel that it's a signature or represents their weakness. And they don't understand the value of having something to keep their body steady. I always try to explain to older folks that, even though a cane may look like, you're crippled or whatever, whatever your interpretation is, the cane does provide some steadiness, and it helps calm the brain, because if the brain feels like your body's wobbling, it's going to search for the most stable position, and that's where falls happen, with that situation. And I'm very hopeful that trying to convince older adults using walking sticks is kind of a hip thing to do, so it gets away from that stigmatism that, you've got something that to stabilize yourself. And actually you get better exercise with walking sticks. So you may have heard me say that before, that Nordic sticks are good both indoors and outdoors. We always want to promote sometimes family visits. So I say facility visits, again, this is focused on long-term care, but just making a prescription to the family. Back in the old days when we used to write handwritten prescriptions, the two favorite prescriptions that I would write were not medications. One was, you must get more sunshine, for your vitamin D. And the second one is your daughter must visit you once a week. And a lot of times the older adult would take that prescription and say, look what the doctor wrote to the daughter, and it worked. I mean, it was amazing. Yeah, so again, just the idea of trying to promote safety through questions. So we'll ask, has anybody ever made you feel uncomfortable? I actually asked, do you feel safe at home? Are there any issues going on? And it just reminds me, like back when we were doing home visits in Chicago, oh my gosh, some of the things that would go on that, you would never find out in the clinic, either by direct observation in the home or by just asking folks. And, we found out that one of the grandchildren of one of our clients or patients was a drug dealer, and thought it was entertaining to slip a little cocaine into grandma's coffee, and so we had to bring in adult protective services to to deal with that situation. But we would never have learned that had we not been in the home setting. Another quality that's important in cultural sensitivity is trustworthiness. So it's important to not delay, observations or findings. That it should be very direct, if they want that directness, right? So sometimes, particularly like with cancer, like if we found out that you had something, do you want to know about it? And sometimes folks will say, well, tell my daughter, and that's good, or I really don't want to know. Now that's a double-edged situation, because on one hand, a lot of times older adults don't always want to engage in memory testing because they're afraid of what they're going to find out. And in most cases, that's a situation where, folks actually have preserved memory, but they're just fearful of loss of memory. But anyways, the point is that you always want to explain what you're doing and looking for alternatives. So if it's simply asking memory testing through the mini-cog or through the slums test, and people may be declining, to do that, and you say, well, how about just let's name some animals? And so you do category fluency, and they should be able to name 15 animals or more in a 1-minute time period. Otherwise, if they don't, then they likely have some form of cognitive impairment. Emphasizing peer-to-peer support. Storytelling is really important. So reminiscence therapy, telling stories. And then also providing transportation. I mean, that's huge. And one of my biggest concerns with our, particularly with our tribal partners, as part of our GWEP project, is that about 2/3 of the older adults have troubles with transportation. They don't drive themselves. And this has been a general, I don't know if you know anything about the 2020 U.S. Census, but the U.S. Census just reiterated that particularly in reservations, that Native Americans are much less likely to have access to any kind of transportation than the general population. So again, that's a huge concern. Another key point for culturally sensitive care is, again, emphasizing collaboration. So if somebody is in a long-term care facility, you ask them about what was their life before they moved to the long-term care. And then it's a gradual process by which you come to an understanding. And that's why we always have to ask and re-ask these things like the geriatric 4Ms. Just because you ask them once, it's going to change over time. And just as a case in point, this is great. In clinic, lady comes in, 88 years old, brings in paperwork for nursing home placement. And I said, she's living in assisted living. I said, why do they want you to go to the nursing home? She says, I don't know. She says, after my husband died, I guess I wasn't doing so well. And it was true. She was grieving. And so here we are 6 months later, we're told that she's, self-care, neglecting herself and so forth. Yeah, that was all part of her grief process. And we eventually got her onto an antidepressant. Her slum score was moderately poor. It was 16 out of 30, 3 months after her husband's passing away. And then after we put her on antidepressants, her score improved to 26 out of 30. So she had a normal score. So her cognitive impairment and her self-neglect was all related to depression. So that's a good example of why revision of the healthcare plan is always important based upon your assessments and your management plans. It's always important to try to accommodate this last point, the older adults' routine. If they prefer to go to bed at 8 p.m. rather than 9 p.m. lights out, I mean that's what you should honor that preference. One of the big things is this whole thing of tough love. If somebody has a preference for eating alone versus eating in a group, I mean, forced socialization is not always in the best interest. You take that gradually if you think this is an important element to reduce social isolation. But again, some people are very content being by themselves, and you need to honor that. Yeah, so this big powerful river, right, going through the big powerful mountains is kind of the connection here with the empowerment. And it's important to make these connections with different levels of healthcare providers. And again, trying to accommodate the language preferences, if any. And then also at some point to identify spiritual beliefs. So a lot of times I'll ask patients, whether they've been going to church or not. Or church services, and they'll say, well, I used to, but not anymore. And then that leads to a whole set of questions about why they stopped, and so forth. Another George O'Keeffe painting here with, enlarged flowers, desert flowers. And one of the key points in cultural sensitivity is to understand the voice and the choice. So always offering a choice of different venues or opportunities, always allow people to express their concerns. Maybe that's through a resident council or what we call a stakeholders group. A lot of times people are not calling it stakeholders anymore. They're calling it community interest groups. And then just looking at trauma-informed care strategies, certainly training. All of what we're doing right now is part of that process. And then if you are working in a long-term care facility, to really apply that in terms of quality assessment and program improvement, or QAPI. This can apply in the clinics too, and in the hospital settings. So no matter where you practice, quality improvement can also always look at how people are addressing, historic or just trauma informed care. And this is an abstract painting by Helen Frankenthaler. And I don't know, I don't have much of an interpretation of this one. I just like the primary colors in it. Simple enough. And then just finally to talk about some of the recognition of healthcare disparities. And so American Indians have one of the largest unmet mental health needs. Part of that is due to under recognition and also lack of resources. And just recently, post-COVID, there's been a 6% drop in life expectancy of older Native Americans compared to the white population. So it's 3 times different, and that's pretty dramatic. And quite honestly, I'm not sure why, but that's something that needs to be reckoned with. And a quarter of older adults of Native American background express some form of discrimination during their health encounter. So whether it occurred or not, their feelings are that something was amiss. And so again, it gets back to that, whether it was intentional or unintentional, part of that. And as a provider, I'm not always sure how I get that feedback. So it's like, if you don't know exactly what you did, wrong, or how you offended somebody, how are you going to know how to correct it? And so I always use that as a feed forward, moment, like, I always ask at the end, is there, of the clinical encounter, is there anything else that you want to talk about? And, going from there. And then this other part of, having a higher fall rate in older Native Americans compared to the rest of the population, that may in part be hard to interpret, other than it may be related to a higher incidence of diabetes and neuropathies. So that would be my first interpretation, but again, I really don't know. Yeah, and this just emphasizes graphically Native American versus white, Hispanic, and Black that have injuries, related to fall. So this just emphasizes that basically, for the most of the populations, 1 out of 10 falls result in injuries. So it's kind of good news, bad news, right? 90% of the falls are without injury, but of those 10% that have injury, 10% of those then actually die from that injury. So those are important considerations. Just some other health disparities, increased incidence at the bottom here, the green line, of diabetes, 6% of the population, 16% of the population versus half of that for whites. Although that number's gone up. I mean, here in North Dakota, obesity has gone up from 27% 10 years ago to 34% currently with the last U.S. Census. So this is kind of interesting. So when you have populations of different ethnicities and races, the whole question is, are there differences in strokes and or myocardial disease? And you can see here that just a little over 20% of the white population will have cardiovascular deaths, so 1 out of 5 due to chronic conditions. But that number is almost half that with the American Indian population. So, what is it about that resiliency? And so I think a lot of times we emphasize health disparities in a very negative connotation. Sometimes those health differences actually provide a lot of interesting thoughts about resiliency, and there's other examples of that. I don't think I have that in here, but another issue to think about is cognition and brain health, particularly in Indian country, where 1 out of 6 Native Americans over the age of 45 experience some sort of cognitive issues. We don't know whether that's changed post-COVID, but long COVID and brain fog are a big deal. And so the expectation is that brain health is going to become an increasingly more important over the next decades. And it may start off with just, these issues of forgetfulness. And on top of that, like I say, people don't like to advertise the fact that they're being forgetful. So even with that, it's, I think, helpful to work with just older adults in general to figure out strategies by which they can maintain memory integrity, and then also looking for ways to prevent a further decline, particularly if they have mild cognitive impairment. Right. So if you have mild cognitive impairment, 50% of those are reversible. Right. And so everybody says, why I get this from doctors all the time. Why are we screening for memory loss? And there's nothing we can do about Alzheimer's. And the answer is, yeah, well, we may not do so much about Alzheimer's, but we can do a heck of a lot with mild cognitive impairment. And so if we can get people on the trajectory towards sustaining their cognition through increasing physical activity, making sure their blood pressure is 130 systolic or lower, making sure they're doing cognitive games and engagement, maybe nutrition, plus or minus. That the verdict is still out on that one. But again, these are why we're asking those questions. And again, there may be some cultural reasons why people are not enthusiastic about their testing their memory. Yeah. Oh, here's the study that I was looking for. I didn't know whether I included this slide, but if you look at this green line, over time, going from 1996 to 2013, look at the incidence of drop in chronic kidney disease or kidney failure in the Native American population. I mean, it's dramatic, and these are chronic disease management programs, and so it just goes to show you that there are really some amazing statistics about resiliency and responsiveness to health promotion programs. So I think that this is to me, very, very encouraging. And what is it about these similar chronic disease management programs that are more effective in Native Americans than in other populations? You can look actually, with the white population, these chronic disease management programs that almost made it look worse. They went from like 10% up to 15% more, renal failure. So again, some of these programs are incredibly effective when we talk about health promotion. A big one is social isolation, and just to emphasize that it's an objective feeling of separation from other people, even though you might be in the middle of a group of people. In one study here through UND, they found that 25% of Native American older adults reported to be socially isolated or lonely. And the last point there is that prolonged social isolation has detrimental health consequences, and really are the equivalent to a cigarette smoker, a habitual cigarette smoker, in terms of disease outcomes. So there's a couple of thoughts about how social isolation is an issue. It may accelerate aging, and a variety of other concepts that really are again driving that chronic disease problem. So some of the things that we look at for reducing social isolation is gathering, and that's what we do at Spirit Lake. We have a gathering once a month. It's not we; it's the tribe has had this for quite a while, and our program at UND has just simply tried to help collaborate with health promotion games that we're doing. So Dr. Minocha here maybe can speak on this down the road, of all the different kinds of healthcare games that we've created, between Wheel of Fortune, healthcare bingo, and any number of things. And these are just different ideas: intergenerational encounters, storytelling, reminiscence therapy. And then I already mentioned about this prescription for regular family visits. I don't think I can do this electronically. I've tried, and I can't do a handwritten prescription on electronically for some reason. So I guess I'll have to find some antique, handwritten prescription pads somewhere. All right, so there are resources here. The National Indian Council on Aging has a bunch of programs that help address this social isolationism. And the Center for Medicare, Medicaid Services has a variety of resources, fairly new, from 2022, that look at tribal nursing home and assisted living. And mind you, tribal, not all tribal organizations or reservations have nursing homes. So we're talking about area long-term care facilities within proximity of reservations. So just to summarize, this Claude Monet painting of two women overlooking the cliff, very precariously at the edge of the cliff. I'm not quite sure what the significance of that is, but again, looking at that kind of fuzzy horizon, and just the question of a lot of these issues are not as clearly focused as we would hope. But it's important to consider cultural diversity and this whole conundrum of and tension between assimilation and celebrating our differences. And I tend to just quite frankly lean on the latter part of this. I so much enjoy diversity that I learned tremendous things from that. And then also just increasing our awareness through education and training to help people recognize and the challenges that are part of our biases, and really to try on a day-to-day basis to promote more inclusive and equitable practices in healthcare.